and this is a new onset, or the patient admitted for the first time for heart failure. Looking at de novo heart failure, 43% overall patients in this is from the global heart failure registry data, where de novo heart failure with rates ranging anything between 20% North America to 79% Southeast Asia. So in our part of the world, we do have a lot of patients having de novo heart failure. So in PREVENT study, 66% were newly diagnosed with heart failure, reduced ejection fraction. So quite high incidence of de novo heart failure. When you look at the benefit of sacubitril valsartan vis-a-vis enrapil in this group of patients, so there is a significantly lower incidence of composite of CV death or heart failure rehospitalization in patients who started with sacubitril valsartan. These are the de novo heart failure patients started on sacubitril valsartan in the hospital itself before discharge. So there, the composite of CV death or heart failure rehospitalization is significantly less compared to a patient who had not started the drug in the hospital. The transition study is in initiation of sacubitril valsartan shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed or that is de novo heart failure. And basically, we'll be discussing about the subgroup analysis of this transition study. So the subgroup are based on heart failure history, like newly diagnosed de novo heart failure or chronic heart failure diagnosed prior to enrollment of the study. So this was basically primary endpoint was the assessed tolerability of the treatment as the proportion of patients who achieved the target dose of 200 milligram twice daily at the end of week 10 after randomization. So this was the primary endpoint, and there is a secondary endpoint of the initiating sacubitril valsartan shortly after hospitalization in newly diagnosed heart failure patients, proportion of patients who received and maintained any dose of sacubitril valsartan for at least 2 weeks leading up to week 10, and rates of permanent study drug discontinuation due to adverse events. And this was published in 2020 in European Journal of Heart Failure. And when you look at also sacubitril valsartan, what they found that there is a reverse remodeling. There is what is called a reversal of remodeling with use of sacubitril valsartan. So when the LV ejection fraction, there is only 6.5% had a LV ejection fraction, which was effectively increased by more than 50. So there are only 6.5%. There's a reverse remodeling with the drug, so that is enrapil. But when you look at sacubitril valsartan, 30% could achieve the reversal of remodeling. So there is a reverse remodeling, and this incidence is very high in patients with receiving sacubitril valsartan, significantly more than the reference drug. And so there is an increase in LV ejection fraction, and also LV end diastolic diameter also significantly reduced. Again, a measure of remodeling. So this is basically a measure of remodeling showing significant reversal. So sacubitril valsartan improved cardiac remodeling and pump function more effectively compared to ACEI, and these are the patients with de novo heart failure patients who are hospitalized. When looking at the troponin T, high sensitive troponin T concentration, this is also significantly reduced in patients with sacubitril valsartan. And when you the main endpoint was number of patients reaching the target dose at week 10. So this was 56% with sacubitril valsartan, and this was only 45% with the reference drug. So more number of patients, statistically significantly more number of patients could reach the target dose of 200 milligram twice daily within 10 weeks. And those who achieved and maintained the drug like 100 milligram or 200 milligram twice daily for at least 2 weeks leading to week 10. So that is one of the secondary outcome. That is also significantly more with sacubitril valsartan. And achieved and maintained any dose of sacubitril valsartan for 2 weeks leading to week 10. So there was no significant difference. And permanently discontinued sequential valve due to adverse event was also less, and this is significantly less those who could achieve the target with sequential valve vis-a-vis NRAP. So the transition study, what it shows that the first line initiation sequential valve in de novo heart failure with reduced ejection fraction patients alongside the initiation other guideline directed therapies is feasible and is associated with a better risk benefit profile than in patients with prior heart failure with reduced ejection fraction. Early intervention with sequential valve should be considered to delay disease progression in patients with de novo heart failure. So the decision pathway for optimizing heart failure treatment, that was the 2021 updated from the ACEI expert consensus. Like any patient with a stage 3 treatment, start ARNI, ACE or R, where they say ARNI is preferred, but 2022 they say that it should be ARNI first. And choice as the foundational therapy along with beta blockers and diuretics. And then you have got choice of other drugs. Like patients with the eGFR more than 30 or more with a creatinine up less than 2.5 in male or less than 2 in female, potassium less than 5, you should go for aldosterone antagonist. And then patient meeting criteria of eGFR with NIH class 2 to 4 SGLT2 inhibitors. And then with the persistent volume overload, of course, you have to up-titrate the diuretic agents. And the patient persistently symptomatic, a black patient, despite ARNI, beta blocker, aldosterone agonist, SGLT2 inhibitors, then it is hydrolyzine isocitrate dinitrate. And patients with a resting heart rate of 70 or more on maximum tolerated beta blocker dose in sinus rhythm, class 2 to 3, it is evaporated. So these are the winner drugs that are effective in patients with heart failure, except diuretic. All the 4 class of drugs, they reduces mortality also, along with ACE, ARB, and ARNI. Clinicians should aim to achieve optimal guideline directed medical therapy within 3 to 6 months upon initial diagnosis of heart failure. The European Society of Cardiology 2021 guideline recommends sacubitril valsartan as the first line therapy for hospitalized patient with heart failure with reduced ejection fraction. Remember, hospitalized patient with heart failure with reduced ejection fraction. This should be stable patients, including those who are on ACE or R naïve. Means they may not be on ACE or R at the first time that will be receiving any medication from that class. So it has to be ARNI that should precede ACE or R. The 2022 American Heart Association guideline clearly says that in patients with heart failure, reduced ejection fraction and NIH class 2 to 3, ARNI is recommended to reduce morbidity and mortality that we have seen. And if it is not possible, then only you go for ACE or R. For some reason, it's not feasible to give ARNI, then ACE or R you should be using.